live and direct from the broom cupboard. Thanks very much for having me. I've followed these talks with a great deal of interest over the last few months, so I'm actually delighted to be able to give you my pearls of wisdom, or so to speak. And I think this talk might be a little bit basic compared to what Caroline's just talked about, but hopefully it will be enjoyable and I guess thought-provoking would be the thing that I'd want to get from it, actually. So as Paul said, the overview of the talk is about cerebral protection, and in particular, the pharmacological aspect of it. So we'll go over why that might be appropriate, what agents are given, and when we give them. And I'm not going to talk about things that really, as anaesthetists, we don't influence. So the surgical aspects of protecting the brain during circulatory arrest cases. So these really are the three sort of main avenues by which we provide cerebral protection during predominantly aortic surgery. So it's hypothermia and cerebral perfusion techniques, intraoperative monitoring, and what we'll talk about or focus today on in this short talk is the pharmacological adjuncts, and in particular, for the time constraints that we've got, we'll focus on two drugs, so that's thiopentone and steroids. Now, just to set out my stall, I went into this really willing to have my entire strategy for managing these cases overhauled based on what I'd read and what I'd learned during preparing this. And the crucial question that I wanted to answer at the end of it is that it is based on what I know now. Is there any value at all in giving pharmacological adjuncts in these cases? So currently my stall consists of probably things that are quite common to everybody. So thiopentone, methylprednisolone, ice, and insulin. Really, that forms the mainstay of what we give as anaesthetists, I think, in the moment for cerebral protection. So I'm just going to start by saying what I did as a final year registrar going to being a new consultant. So over the last 5 years and how that has changed. And then at the end of it, I'll just touch on what I think I might do going forward. So the strategy prior to this was really based on experience as a trainee and copying what everybody else did, which was to give a dose of thiopentone a few minutes before circulatory arrest, aiming for a BIS of 0, essentially, a decent dose of methylprednisolone, some actrapid, and loads of ice. And I changed about a year ago to just altering the timing of the thiopentone. And the rationale being that if we gave it during cooling when the CO2 was high, the cerebral blood flow was high, and it might have more time to work or might work more effectively if it was given then rather than just before circulatory arrest. And so I've just put this chap. So this is Richard Feynman, who's one of the most famous physicists, certainly of the 20th century. And if you want to risk provoking an existential crisis in yourself, there's a very good video on YouTube about where he answers a question about magnetism. And one of his main points is that to explain things, we have to have something to rationalize what we're doing. And it sort of came to mind when I was thinking about this talk that a lot of the stuff that we're doing is based on assumptions or things that we accept as true, because otherwise it would make no sense at all. So why do we give cerebral protection? Well, I think it's probably well documented over 35, 40 years now, that there's a dose-response curve between the duration of circulatory arrest and neuromorbidity. And based on observational studies, that safe period we think is about 40 minutes. One of the things that we've accepted over the years is that hypothermia reduces cerebral metabolic rate and oxygen consumption. But having said that, lots of groups over the years have documented that there's still residual EEG activity even when the patient's very cold. And therefore that raises the question of whether there are opportunities for us to reduce cerebral oxygen consumption further with pharmacological agents. The rationale being that the neuro dysfunction post-circulatory arrest is due to ischemia or emboli or something else, and these things would provide a degree of protection over and above hypothermia. So I guess the first question is, what does everybody else do? And you'll see from this survey, this is 20 years old now. This was a survey from ACTAC, as it was at the time, sent out to all the cardiac anaesthetists in the UK, asking what people did during deep hypothermic circulatory arrest in thoracic aortic surgery. And this is what sort of things people were doing at the time, and it's really very similar to what we're doing now. But you'll notice that not everybody uses something, which is, I guess, the first thing that's interesting. Even more interesting, when the author has asked a few more questions, asked about what do actually people believe in, and a staggering number of people actually didn't believe there was sufficient evidence for what they were doing at the time, which I don't know whether it's different these days in terms of what people think, but it's certainly an eye-catching observation. And this notion about using pharmacological protection is not really new. So this is actually a review article from 1985, where the authors had discussed the variety of experiments and evidence to support the use of barbiturates in protecting the brain during periods of ischemia, both focal and global. They've reported quite a few studies, mostly in animals, that there was a decrease in infarct volume after circulatory arrest with administration of thiopentone. And you'll see that one of the problems with research in general, and certainly with this sort of research, is that often the doses of drugs that are being talked about far outstrip what we'd give in clinical practice. So therefore, we have to ask, is it really applicable to the population that we're serving? And again, this notion isn't new. So this is a study from 1966. I couldn't get the original article, but this notion of barbiturates protecting or increasing tolerance of the brain to anoxia is not a new thing. So we'll talk in more detail about thiopentone, and because this is probably the most common drug that we give in this sort of case, and it won't probably shock anybody to realise that the main area of study in this area has been in areas other than circulatory arrest cases. So there's been lots of work, mainly in stroke and cerebral vascular surgery, cardiac surgery in general, and in post-cardiac arrest patients. And none of those studies have really shown any benefit in giving thiopentone. In the context specifically of circulatory arrest, small studies, thiopentone being part of a bundle, and again, huge doses really typify the evidence base for this drug, which is in general a widely prescribed drug in this scenario. And of course, there are other problems with thiopentone, which I don't think necessarily get as much consideration as certainly I didn't give beforehand. In that if we're giving big doses, there's certainly a possibility that that drug hasn't cleared, leads to delayed extubation. Is it neurotoxic in its own right? And if the mechanism of protection is to reduce oxygen consumption, why hasn't it been shown to be beneficial? And almost certainly that's because we're trying to simplify an extremely complex problem. And so to really critically appraise it and come to an appropriate decision based on the evidence that's in front of us, the topic becomes very confusing very, very quickly. And so some of the problems with doing this sort of research, well, there are many. If you look back at the annals in the literature, a lot of these are old trials. If you look at the meta-analyses, there's no consensus on practice, so it makes analysing the data overall extremely difficult. Perfusion techniques have improved dramatically. And really, I think that modern practice for surgery on the aorta combines a very short period of true circulatory arrest with selective cerebral perfusion. So one could argue that the work that's been done before really doesn't relate properly to what we're doing at the moment in terms of a combined surgical perfusion and anaesthesia approach. There's also things that are really out of our control, and I think there's an increasing notion that unfortunately as an anaesthetist there are very few things that we can really change in terms of interventions that are beneficial to the patients. And a lot of the issues are really it's surgical issues, so the extent of surgery, the risk of atheroma and debris causing cerebral emboli, the effectiveness of cerebral perfusion techniques. Which segues onto steroids. So the rationale behind steroid use is this sort of catch-all term inflammation. And for those who have followed particularly ICU and sepsis research over the years, this notion that steroids will reduce pro-inflammatory cytokines. And I think for anybody who's read around that subject will know instantly that those sort of treatments to reduce inflammation have not translated into benefit, and in some cases have translated into harmful things. But they did, until relatively recently, have quite a long history of administration, especially in the pediatric population. And personally, I've sort of come round to thinking that these things have actually the potential for real harm. So in traumatic brain injury, they can cause harm. And really the things that I've noticed as a danger for steroids is hyperglycemia, which we know from registry data and association guidelines does worsen outcome. So we might ask, well, what's the evidence for this? Well, there's actually quite a nice meta-analysis and systematic review from quite a few years ago that not only showed that they didn't steroids didn't help a patient, but they actually worsened outcome. So they increased myocardial damage, increased the rate of AF, and so really this for me is a no-no in this context. But the next question will be, well, that doesn't include circulatory arrest patients. So is there any data about that? And yes, there is. If we're interested in circulatory arrest in piglets, there certainly is. And so if we are going to use this as data by which we give treatment, then I don't think we're setting our standards for rigor and evidence-based medicine very, very high at all. The final question that I thought about was, when should we give the drugs? And this sort of relates to what I'd said about my change in practice about giving the thiopentone slightly earlier than I normally would do. And to say that there's a paucity of data in this area is one of the most striking understatements I can think of. And so should we give thiopentone before circulatory arrest? I thought, does my theory about giving it a bit earlier make any sense whatsoever? Because the other aspect of this is that a lot of the steroid trials have involved administration 2 to 8 hours preoperatively, which I've never seen anybody do. So it's one thing, is the drug that we're giving harmful, but the other thing is, are we actually going to achieve any benefit whatsoever by the way that we give it? So based on that reading and so on, I sort of wrote down a few statements in that most of us are doing things which we are not sure are effective. We probably don't think they cause harm, but are they really necessary in the age of selective perfusion and better perfusion and surgical techniques? And so I'll give you a recent example of a lady who wasn't planned for circulatory arrest, but we ended up doing it intraoperatively. She was cooled down. She had really 1 minute of true cerebral ischemia, but with all the head drugs. So is there any justification for giving drugs that we don't think are effective, and in some cases may be harmful, for the sake of 1 minute of ischemia at 20 degrees C? And my answer was, I'm not so sure. So hopefully there'll be some, I can't see the chat at the moment, but if people want to put their head above the parapet like I have and tell us what they do, and of course we might find a more accurate reflection of what's happening at the moment in the UK with the latest ACTAC audit, is that I'll probably continue to give thiopentone during cooling, but I may well abandon the use of steroids completely and focus on trying to avoid harm rather than trying to add benefit that I don't think is there. The other notion, which I think we all have to be aware of, is, will I be criticised if something happens and I haven't given anything? Which is an interesting question, and it's food for thought, really. So thanks very much. I know, well, it was a brief journey through cerebral protection, but I'm very happy to take questions. I'm going to just stop sharing my screen now.
Thank you, Mike. That was really raised some really interesting topics. Do you think that the absence of evidence is enough to change your practice?
I think with thiopentone, no, because I think that's probably a relatively harmless drug. With steroids, I think the question is different, because I think there is evidence of harm in certain populations. And I guess the one thing we don't know is that, the duration of hyperglycemia would be the concern. And if that's prolonged, what's the effect? We don't really know. So I would say that in the absence of no harm, it would be safer to avoid it. I don't know. I haven't made a decision yet. I'd be interested to see what everybody else thinks. So I'll probably continue to give thio, but I think almost certainly I would hold off on the steroids for a while.
So it's just interesting, isn't it? Because we've all kind of grown up giving these drugs, seeing all of our bosses give these drugs and thinking, what I'm going to do every marginal thing I can to protect the brain.
Yeah.
you know, if you were to go to coroner's court and say, I didn't give anything because there's no evidence, you know,
Yeah, it's
that's
tricky,
probably
isn't it?
reasonable. It's probably reasonably defensible, but then they would say, actually, what would 50 other cardiothoracic anaesthetists do, and 49 of them would give the drugs.
Yeah.
So
it's, I think it'd be very interesting to see what comes out of the aortic dissection audit, because even 20 years ago, there were 40% of respondents who didn't give anything, which is a lot, isn't it? Really. And I've only worked in 2 centres, and everybody's given something. So either maybe the data collection wasn't accurate enough, I don't know, but it'd be interesting to see, because we've got very, people from all around the country here, haven't we? Be interesting
all
if
around the world,
anybody's.
I think.
Yeah. Does anybody not give anything?
So Carlos had his hand up for a question. So if people want to type their recipe in the chat, I'll let Carlos ask you a question, and then maybe we'll see if other people have suggest what they do.
Hi, Carlos.
Yeah.
Nice to see you.
Hi, Mike. Carlos here. Yeah, thanks very much for that very good presentation. And yeah, I mean, my contribution would be that I worked in I did a fellowship in Canada for 2 years in Toronto General, and we gave nothing, absolutely nothing. So no ice in the head, no drugs, no IO, sometimes steroids, but not for brain protection. And the outcomes are one of the best outcomes in North America and in the world. So I think there's a lot of equipoise, and but unfortunately nobody's going to do a randomized controlled trial of ice or anything. But so yeah, it's interesting, and I think we'll be probably having the same discussion year after year.
Yeah.
Well, we've got to have something to talk about, haven't we?
Yeah.
So
exactly.
The comments are coming in. So Tom Gilby of the ACTAC aortic dissection fame is on the chat. Steroids 37% and thio 34% so far. 3 months to go till the end of the audit, or 2 months, sorry. Satch Mehta, who's one of the consultants at Harefield, says same for his experience in Vancouver. They did ice but no drugs. Lejos, I'm not going to try and pronounce your surname. I'm sorry about that, but I will embarrass myself here for Teams. Rigorous glucose monitoring, hypoglycemia can be prevented with reasonable success. A lot of ABGs. I'm not saying I'd fight for steroids if there's no evidence. The conclusion that I give what the surgeon wants. Evidence it improves the relationship.
And that's important, isn't it?
What about the usefulness of NIRS? I have a feeling that's going to come up in a later talk. And sometimes in Bristol ice, nothing in Rotterdam in the Netherlands, says Sylvia from, I think she's in Bristol at the moment. So there we have it. So a jury of your peers would defend you for giving nothing.
Okay, I'll screenshot this then.
As would the evidence. But also you can give something. That's it's one of those things that it's a small group of patients, and it's like the old parachute study. You're not going to stop doing something which doesn't have dreadful outcomes, but you're within your right to do what you can to improve the situation for these patients.
Yeah.
Any other questions for Mike? Otherwise, we'll let him go and pick his children up. No, not so far. If you want to put them in the chat or send me an email to the info@cardiothoracicanesthesia.com address, we can get any other questions to Mike and he can respond at his leisure. Thank you, Mike.
Pleasure. Thanks a lot.
Cheers. I'm going to ask Joe Metcalf, who's one of the senior perfusionists at Guy's and St Thomas's, to now share her screen and present to us